Tony and Doris, we can't thank you enough for sharing your story. Don't sit down because we'd like you and all the other speakers to come up to the front table. And excuse me, at this point, we'll take comments and questions from the audience. So please, all the speakers come up. You've got your little name tags there. While people are coming up, I just wanted to take an opportunity to introduce the chair of the National Cancer Policy Forum, Ed Benz, who's over in the right part of the audience here. And Ed's been our fearless leader. He was actually my fearless leader at work for many, many years. He didn't have gray hair when he first met me, but I fixed that. But Ed has been a terrific leader of the National Cancer Policy Forum and to a large extent responsible for us being able to do this workshop. So thank you, Ed. So why don't we start over here? If you could all introduce yourself by name and where you're from, that would be terrific.
Hi, my name is John Gardenier. I'm retired from the National Center for Health Statistics.
Could we just make sure the microphones are at appropriate? I want to make sure everybody can hear. Yeah.
Is this better? Can everybody hear me now?
Good.
Okay, good.
Good.
My name is John Gardenier. I'm retired from the National Center for Health Statistics, but I have one question as a cancer survivor. I had prostate cancer a while back, and my question is relatively simple, but it'll get more complex. How can patient navigators help patients deal with the providers? The problems that I ran into with providers were several. I was very fortunate in that I have all the advantages that that other people don't have, that need navigators. So I was better able than most people to act as my own navigator. Nonetheless, I had serious problems that I did not hear addressed today. I was diagnosed with a relatively early, not the earliest, type of prostate cancer, and I was told that I had two options, surgery or radiation. I was not told that there were several varieties of each. But I'm a researcher by nature, and so I went online, and when I went to a surgical-oriented website, I was told that if you have cancer, you absolutely have to get surgery, except in a vanishingly small set of cases. But and you may need some help from the internists or medical people afterwards. But the basic way to get at cancer with a successful outcome is surgery. I went to another website that was internal medicine operated. And they said, the last thing you ever want to do with regard to cancer is have any surgery. You absolutely should do everything you can with internal medicine first, and then try other things. So I said, all right, there's nothing there. Although those sites are supposed to be authoritative, they're not credible. So then I looked at other things, and I found sites for each specific type of treatment. And every one of them told me there were horrible, horrible side effects that I could get for the rest of my life from every other form of treatment except the one they recommended. Who was I to believe? Well, they scared me enough about side effects of treatment that I decided to go with the one with perhaps the least prospect for a direct cure, but the least problem with side effects. So I went for cryo. When I went for cryo, my PCP had, he had told me he favored surgery or radiation, but he had no objection whatsoever when I decided to go with cryo, understanding that it wasn't as well proven as some other things. Well, it turned out later the cryo was not totally effective. It was initially effective, but I got a rising PSA trajectory following it, had to have follow-on radiation treatment, which thankfully was totally successful. And I'm fully cured now, and I'm grateful to the entire medical apparatus in oncology, don't get me wrong. However, when I came back to my PCP and told him that I had decided on cryo, he had no problem with it. But when the cancer returned, he became furious at me, absolutely chewed me out, up one side and down the other. How could I be so stupid and careless and ignorant as to go for cryo? Although he had no problem with it until it turned out not to be totally effective. Of course, I had to change PCPs. But my frustration when I hear this, and I agree, I'm very thankful for all the speakers. You all spoke very well. You all made excellent cases. And I'm a total believer in patient navigation systems like you discussed. But how the heck can you deal with the problems I had?
Okay, so I think the basic question is, and we all know this, for many cancers, there are multiple options in how to approach the cancer. Some of it, so your choices depend on who you get to see, which is sometimes a random event. And sometimes you do see multiple people and you get conflicting recommendations. So from our panel, how do the navigators help with what for a layperson or even a scientist is going to be very, very difficult to sort out treatment A versus treatment B versus treatment C. Electra?
Right. Okay. Thank you. Thank you for sharing your story. And sorry, we just didn't have enough time to talk about cases like that. But that it's not an uncommon occurrence. So, for example, women need to choose if they're going to have a mastectomy or a lumpectomy with radiation therapy, and that is a difficult decision plus reconstruction. So we do see it across different cancers. So what our navigators do is they get this input from the patient. What has your doctor told you? What do you have questions about that? And then they try to act as a bridge across all the physicians and explain to the patients in English what the treatment options are. And a couple of things that are important are, first of all, patient satisfaction with the decision that they've made about treatment. And so that is another outcome that is starting to be measured in patient navigation studies, in that the patient navigator will walk the patient through all of these treatment options and help them make a decision based on their situation. The second is our navigators are trained in what's called the PACE technique, which is a system that helps patients learn how to talk to their healthcare providers. And both of those techniques help the navigators, help the patients with exactly what you mentioned.
I totally agree with Electra. So we do deal with that quite a lot. There's a lot of decisions involved. There's, a lot of personalized treatments, and certainly when you go online or talk to other people that you may know in support groups or just in, your life, there's a lot of conflicting information that you get. So we try to, help the patient as best we can make that decision and help them when they're talking with their providers to get that information. And sometimes it relies on us that as the navigator, I'll call the physician and say, I've had this conversation a couple times, you really need to explain this better, or do you mind if I, interface with the patient and go through this with them so they can help to understand that a little bit better.
Harold?
In hearings that we held around the country, we heard the testimony of men who had prostate cancer who had never been told anything except cut it out. real actual testimony. And so it is a serious problem, particularly if you don't know that there may be other options that you could consider. At the Ralph Lauren Center in New York City, we confronted that problem by having a nurse navigator who specifically spoke to patients who had a diagnosis or had an elevated PSA to start with. First of all, what is an elevated PSA? What does it mean? Somebody should explain that. In our case, we use Valerie Souget, the particular nurse navigator, to do that. Patient is sent to a urologist and there's a biopsy done and it comes back Gleason 7. What is that? Again, the nurse navigator would talk to the patient and explain what is a Gleason 7. And then the question comes up, what is the treatment for this? Should it be radical prostatectomy? Should it be radiation of different forms, as you raise? Should it be watchful waiting? And so in our center, we made it certain that patients were seen by different specialists. In other words, not just the surgeon, but the surgeon and the medical oncologist and the radiation oncologist, so that a rational approach could be taken. There's a lot of debate about what is the proper treatment for prostate cancer, a lot of debate. The Prevention Task Force, for example, has talked a lot about whether you should get the PSA at all. I think it's in a more balanced position right now. But it's a huge problem, not just especially in prostate cancer, also in breast cancer. That patients need to know what are the options, and then they hopefully could make an intelligent choice knowing all of the options. But we should never have a case where a patient is not explained what all of the options are.
Okay, thank you. Randy?
Thank you, Larry. My name is Randall Oyer. I'm a medical oncologist in Lancaster, Pennsylvania. Thank you all for your wonderful talks. My question is for Darcy. You mentioned about caseload per navigator, and you mentioned 5 domains of activity. I was wondering if you had an acuity scale that you use to manage your navigators and their activity.
Yes, we do. Unfortunately, I didn't include that for some reason, but we do have a acuity scale that we use that takes into account those socioeconomic factors as well as the different modalities of treatment that may be recommended. We have a generic one, and we have one for our head and neck and our breast cancer population. So I'd be happy to share that with you.
So George Weiner from the University of Iowa. First of all, thanks to the panelists for great presentations, and in particular to the Burns siblings for sharing your story. It really does put this all in perspective. My question relates to the discussion of the nomenclature and the professional nurse navigator versus the lay navigator. And I think we'll hear more about that over the next couple days. But how do you figure out at which point in time what is needed for the patient? Do they need a nurse navigator to help describe surgery versus radiation versus cryoablation to the patient? Or when are they lay navigators in a better position to help the patient with their appointments, et cetera?
Hi. What we usually do is if the patients come to our system through the community outreach in our lay navigation system, they'll usually contact one of us as the nurse navigator, and we'll meet with them collaboratively to go over what they understand. In other populations, what we do is the nurse meets with them first, and then we'll make them aware that we do have lay navigators, that they may find it helpful to meet with one of them. Most of the time, we're providing the education as the nurses, but we make the patients aware that we do have lay navigators if they'd like to speak with them. And then we work really closely with them. Sometimes our lay navigators will call us as the nurse and say, I think they're a little confused here. I think we need you to come back and call them or meet with them. So we work really closely with them.
Electra?
I just want to make a comment that there are many models of navigation in many healthcare systems, and we don't have the same type of model that they do at Christiana. So I think people need to be very open to different models. All of my navigators are lay navigators in the clinic. I do have a social worker who is the coordinator of all the navigators. As Dr. Freeman mentioned, you have to have a conductor for the symphony. And so I think you have to look at your situation, et cetera. So my lay navigators do emotional counseling, et cetera, and they know when to call the nurse and pass it over to the nurse. And I will tell you that the nurses, the whole clinical team, they now cannot get through a day without the navigators. It's a symbiotic relationship.
Harold?
In Harlem, for a very long time, we faced the problem of what poverty causes. So navigators that we've used for the most part are navigators that deal with those issues. Do people have insurance? A common problem in Harlem especially, but also in America. Do people understand the communication issue? Complexity of the system moving through to 4 or 5 different places. Still, non-professional people can handle issues like that, alleviation of fear. So I think that if you're dealing with the issue of disparities, the non-clinical navigator can have the power to solve most of those. It can call in specialists, a social worker, and so forth when those problems may be severe. At the point where the patient has cancer, then the medical people are called in more so. But in Harlem, where we work, the non-clinical navigator stays with the patient while the nurse does the other role. You find that people who are busy practitioners like nurses and doctors generally don't have the time to spend to explain things that people could sit down, lay navigate. So we believe that the team of lay and nurse and professional navigators should work together, particularly after the point of a cancer diagnosis. So I would separate the function. If you're dealing with disparities in a poor community, and that's your primary target, which I've been most concerned about, it seems to me that the non-clinical part is the most important part, because if you don't have insurance at all, or you don't understand, or you don't know where to go, those are the factors that cause late diagnosis. The combination of the person who's a non-clinical navigator, the lay navigator, and the professional navigator for the part where you need to have expertise, like we were discussing prostate cancer just a minute ago, that required a person who understood medicine. So we believe that the complement between the non-clinical navigator who could stay with the patient the whole time that they're needed, combined with the person like the nurse, social worker, together is the best combination.
Great. Thank you very much. Yes.
Hi, my name is Julie Pierce. I'm a nurse navigator at Virginia Hospital Center in Arlington. My question is for Mr. Burns. I see that you have listed you're a peer mentor. Did you receive any training or educational support? And if so, what did it look like? And how do you think, as a peer mentor, you're best utilized by the healthcare team?
So Whitman Walker does provide training for their peer mentors. And I'm listening to Dr. Freeman and a couple others panelists speak. Oftentimes with what I do with some of my mentees, I act as a go-between. I can accompany them to their doctor's visits. This is primarily around the issues of HIV, adherence, and that kind of thing. And kind of what Doris said, you know, we kind of break it down into layman terms. I also can agree with Dr. Freeman, because we have been through it. We can kind of relate to what they're going through. And so oftentimes we can act as a bridge. Does that answer your question?
Yes, thank you.
Great. Thank you, Tony. Brenda?
Hi, Brenda Nevajohn with the Oncology Nursing Society. Excellent panel. From the envision of the concept to the recognition at the end of how that affected somebody's life. It was just a wonderful panel that you put together. So thank you for all sharing. I don't really have a question, but more a reflection. And it came when, Dr. Pesquet, you mentioned the missed colonoscopy, and if you're a hospital administrator, cha-ching, as a recovered hospital administrator. Yes, you worry about cha-ching and the revenue, but you also worry about the expense. And as we develop new roles and additional roles and teams and all that are incredibly valuable, and I'm very, very respectful of everybody who is dealing in the world of navigation, we've got a projected workforce shortage in many of the roles in healthcare ahead of us. We know that already in some parts of the country, we have difficulty finding nurses, and we are hearing some of that from our members, that in cancer centers, positions are going open. And so you've got this dynamic of when there's a workforce shortage, what happens? Wages go up. What happens? Personnel expense line goes up. And I've been in this situation where, you know, you've got to tighten your belt, and how do you tighten your belt? So what you presented in terms of the building of the evidence is so critical. And more than just the qualitative kinds of studies of this is how we do it, but really showing those metrics. So I applaud the information that you pulled together and what you're doing at Ohio State. Because I think we've got a challenge definitely facing us in the next decade or so in terms of general health care, but specifically in cancer care, knowing that we are an aging population. So thank you all for bringing the content that you did today.
Can I make just a comment on that? Thank you for your comment. So two things is that's part of that's not the main reason, but that's one of the reasons we use lay navigators, and we train them from our population. You know, we have Somali navigators, Hispanic, as well as African American and Appalachian, and we hire people from the community who wouldn't necessarily have this type of a distinguished job.